Mike Gibson, Andre Lamy, talking about tranexamic acid and how it can reduce potentially seizures in cardiac surgery. Want to talk to us a little bit about what you did and why?
Well, the bleeding is a big problem in cardiac surgery, and tranexamic acid, which is an antifibrinolytic, has been used for many years. The dirty portion of tranexamic acid is seizures. So we've got about 1% of patients develop seizures after cardiac surgery, which create problem for this patient, obviously. Often they have to be transported quickly to the CT scan. So the idea is that, and also the anesthesiologists have to deal with decreasing the dose of TXA to avoid the seizures. And there was promising results with topical TXA that we put basically directly on the wound in orthopedic surgery. So we did a pilot study in cardiac surgery. We had good results, so we went for a full trial.
So how big was the study? How many people were randomized? What were the endpoints?
The goal was 3,800 patients. Basically, the question is the topical TXA that we put on the heart at the end of the surgery can reduce seizures without increasing the bleeding compared to the intravenous TXA, which is given at the beginning of the surgery. Um, so it's up to both teams. So the anesthesiologist had two syringes, the surgeon had two syringes, so maximum of 10 grams, and each one was giving the dose that they thought was needed at the time of the surgery. Um, Basically, most patients having cardiac surgery or adults were eligible, except those at very low risk of bleedings, like off-pump cases, or high risk of bleeding, like endocarditis, things like that. And the primary outcome, as I mentioned, was seizures. Secondary outcome was red blood cell transfusions. And tertiary outcomes were the blood products, MACE, reoperation for bleeding. And the primary outcome seizure was tested for superiority with Fisher exact test. And the secondary outcome was for non-inferiority. Um, and what happened is that at the second interim analysis that was pre-specified, the DSMB reviewed our data and they wanted to stop the recruitment of the trial due to safety. And we'll look at our data, and a few days after, at the end of November, we closed the recruitment, and we had 3,242 patients out of the 3,800 that were uh, that was our goal. If you look at the patients, they're about this. They equal on both sides. The usual cardiac surgery patient, and most of them had the CABG surgery, and 30% of them had a valve or a combo with CABG. Um, I'll skip the details, but cross-clamp time and everything was identical. And the follow-up was short. It was uh, 10 days, and so were able to turn around the trial fairly quickly and close the trial very quickly after the end of their enrollment. So the primary outcome, so the rate of in the topical was 0.2%, and the intravenous was 0.7%, and we missed the p-value at 0.07. Two reasons. One, of course, is that we were underpowered because the trial finished earlier. And the second reason is that we have very restricted definition of seizures. So we excluded patients who had a stroke
Hmm.
um, because we wanted initially in the trial to prove that, the seizures were not related to stroke, they were related to something else. But so there were three patients, all in the intravenous group, who had the stroke. So you use now a different level of seizures, 0.2% versus 0.9%. Now we have a study that's positive with a p-value of 0.02, but of course it's post-hoc analysis, right? But I'll come back to these strokes. The other one, that piece of information we found is that there was suspected in the literature, but we basically look at what we call closed chamber surgery, so basically CABG, versus open chamber, so basically valve or replacement of the ascending aorta. when you get air in the heart, and you have to de-air the heart at the end of before coming off pump. So the rate of seizure actually was 0.4 versus 1.1. So you have uh, two-thirds reduction in seizure in patient having a closed chamber like cabbage compared to valve patients. So the p-value was again positive. So we'll come back to that. But unfortunately, there was an excess in transfusions that was clearly significant.
In there was an excess of transfusion in the topical arm,
In the
correct?
topical arm, yes,
Mhm. And is
it was
that
clearly
why the
significant.
trial was stopped?
Correct.
Okay.
Yeah. And if you look at any blood products, it's also significant. But reoperation for bleeding, MACE, and lentis were not significant between topical and intravenous. There's some impact on, well, the only impact we found of the bleeding was on the, the dialysis. There were more dialysis with the topical group. And if you control for bleeding, then you can see there's an impact a bit on the bleeding causing dialysis on these patients. So bleeding is not good for our patients. We know that. Um, Also in the literature, there's some meta-analysis suggesting that a higher dose of TXA will give you more seizures, but we didn't find that. We divided the dose in three tertiles, and basically the rate of seizures was virtually identical for the tertile. So that make me suspect there's something else. uh, Suspect there's something else than just the dose of TXA. We'll look at subgroups, and for age, sex, surgery, urgent or elective, or the type of surgery. There's no interaction for seizures and also for bleeding. Um, so the conclusion of our trial, so the topical TXA versus intravenous TXA does not reduce the risk of seizure and unfortunately increase the risk of transfusion. Um, Disappointing, but it brings me more questions. TXA is neurotoxic, and how does it go to the blood-brain barrier? And that blood-brain barrier is very impervious to most medication, including TXA. And how does it go through? And there's a paper published recently showing that, well, some uh, neurosurgeons and neurologists are using microbubbles and focus ultrasound on some specific area of the brain. And they proved that they were able to open the blood-brain barrier exactly where they wanted. And their goal was to deliver medication against Alzheimer's disease. So the mechanism for there, it's basically they have micro bubbles, and with the ultrasound, they make these bubbles get bigger or explode, and they have a temporary disruption of the blood-brain barrier, and their medication went through. So it brings the issue that, is it the mechanism that we have, in a sense that it's just not the dose of TXA, it's more complex than that. And now, if you have TXA in your system at the time of surgery, at the time that you're coming off the heart-lung machine, and you that's the time when you're at risk of bubbles or debris coming out. Um, so it seems to be the mechanism where the TXA that's present in your blood at that time. Um, uh, that seems to be, to me, well, I'll have to work more on that, but it seems to be how these most of the vast majority of these seizures are coming from the um, having air embolism or debris embolism, while the TXA isn't systemic at that point.
Well,
So
that's
there's an issue of timing. It's not just the dose, but an issue is timing and mechanism. Yeah.
really interesting. So it may be an issue of timing. Do you have any plans to maybe do it in a different manner with different timing to retest the hypothesis?
Yes, I mean, we know that giving it topical after the protamine, so we know that decrease the seizures by 60, 70%. The issue is bleeding. So we're thinking of adding a smaller dose with the topical dose at the end. So very much at the end of the surgery, um, that we can reduce bleeding. And that's what we're going to do. We're going to test that hypothesis by measuring the level of TXA, which is not that easy. It has to be done at a specialized lab, and also measuring the effect on the fibrinolysis in these patients for a small pilot study, and then reassess maybe going for another big trial. There's
Wow.
more there's more to this story than
Yeah,
just the dose of TXA. There's more
there
to it.
always is. It's always complicated. You ask an honest question, get an honest answer, and you got more questions. Well, Andre, thank you for joining us. Thanks for educating me about all this neurotoxicity. I'm not a cardiac surgeon. I learned a lot, and keep up the great work. Thanks for joining us.
Oh, my pleasure. Thank you.
Thank you.